Welcome everyone to the joint eMedica and Medical Protection Society MRCGP SCA Essentials webinar for doctors who want to know how to pass the SCA and are going to be preparing over the next the next 12 months or so. Okay, for those that haven't met me before, my name is Muhibur Rahman. I'm a portfolio GP and the medical director of eMedica. I did recorded consultations as part of the old MRCGP, and our endpoint assessment was called summative assessment. That also had video assessments. I was involved in piloting the CSA back in 2006. I sat the first sitting of the CSA, which was in September 2007, passed every case and was awarded it with merit. I'm an author on various study guides and articles about how to prepare for MRCGP. So I wrote the MPS MRCGP SCA study guide. I wrote an article on 10 tips to pass the SCA, which was published in the RCGP GP trainee GP registrar journal Innovate. When the exam was CSA, we ran CSA preparation courses for over 12 years. When it moved to RCA, we ran RCA courses throughout the duration, and we've been running SCA courses since before the first sitting of the SCA. And our team at eMedica have now trained over 83,000 delegates in the last 20 years. Before we get into the main session, let me just go through what we're going to cover, and I'm going to hand over to Derek Palmer from the MPS. As I mentioned, we're running this jointly with Medical Protection Society, and he's just going to say a few words about medical protection before we get into it. But what we're going to cover today, really the learning objectives. By the end of this session, you'll have a very clear idea of the exam format, the schedule, exactly how it's marked, what kind of case types might you expect to get. We'll actually go through an interactive case together to get a feel for it. But we're also going to look at, why do candidates fail the SCA? And then what are the habits of those that don't just pass but really do well? Because you can incorporate those to both make sure you don't fail, but also that you prepare in a way that you maximize your chance of getting a great score. You don't want to be borderline, you want to be comfortable across the pass mark. Okay, great. So let's get into the main content now. Okay, so as I said, this is what we're going to cover. Let's start with the MRCGP SCA. SCA stands for Simulated Consultation Assessment, and it's relatively new because it's only introduced at the end of 2023. So you can only sit this once you're in ST3 or later. And for those of you that started training before August 2023, you have a maximum of 4 attempts. In some cases, you can get an exceptional 5th attempt, but that has got very specific requirements. For everyone that started training August 2023 onwards, and there might be some of you who are attending early, you have a maximum of 6 attempts, and the fee has just been increased. It's now £1,207 per sitting. So in terms of the format, it's basically a simulated surgery. So you have 12 consultations, each one lasting 12 minutes. There's 3-minute gap between cases. So before the first case, you've got 3 minutes to read the notes. Then you have exactly 12 minutes to do the case. Then you have 3 minutes to read the next set of notes. Then exactly 12 minutes to do the case, and so on, until you've done half of them. So after 6 cases, you get a 10-minute gap. The whole thing is done remotely in generally the same practice that you're doing your training in when you're in ST3. And it's a mixture of remote video and remote telephone consult. So generally about 9 of the 12 will be video and about 3 will be telephone. Sometimes there can be a variation. You might have 8 video and 4 telephone, for example. So the whole thing's recorded and marked later by RCGP examiners. And you basically have a different examiner mark each of your 12 cases. So 12 different examiners will assess you. It's available 9 times a year. So in terms of the academic year, it starts from September and it runs all the way up until June, with no exams in December and no exams for the summer in July and August. So you can see the dates, for the next 12 months, they're here. And what happens is you have to sort of reserve a slot. And you can see, for example, for those of you thinking about maybe September, October, the reservations for September, they're closed at the end of June. So it's too late now. If you wanted to sit in September and you haven't already reserved, you won't be able to book when the booking window opens in the second week of July. For those thinking about sitting in October, you have to reserve by the 27th of July, and then the actual booking window will be 4th to 8th of August, and so on. Okay, and then the results come out generally about 4 weeks after the exam. Now, what are they actually looking for? What they're looking for is, do you demonstrate the skills and knowledge that suggest that you can keep patients safe? Do you show adaptability so that you can treat different types of patients with different range of illnesses? Do you manage risk? Are you able to deal with medical complexity and the uncertainty that we often have to address in general practice? And you demonstrate the appropriate behaviors, attitudes, and concerns for your patients, their carers, and your colleagues. Ultimately, what they're really looking for, are you ready to practice as a fully qualified GP with no supervisor? Okay, good way to look at it is GP finals. Now, in terms of how they actually mark each case, there's 3 domains: data gathering and diagnosis, clinical management and medical complexity, and relating to others. Now, the clinical management and medical complexity domain is weighted 50% more than the other 2 domains. And what they have is they have these generic descriptors, which is broad things they're looking for in each of these 3 domains for any case. But then every single case has a specific mark scheme for that case, specific things that they're looking for. For example, the specific things that they might be looking for in data gathering might be different in a patient who's presented with leg pain compared to a patient who's presented with dyspeptic symptoms, compared to, what are the specific risk factors, the specific red flags. Whereas there's generic things that they're looking for. So for example, in data gathering and diagnosis, what they're looking for as a sort of general theme is, are you systematic in how you gather your information? Do you organize the relevant and targeted information? I.e., you're not wasting time asking vague things to everyone. You're able to hone down and ask the relevant things, because otherwise you're just not going to get it done in the time. Do you have a structured and informed approach to problem solving? Because remember that diagnosis is in the data gathering and diagnosis domain. So it's not enough that you can just take a history. You've also got to be able to solve the problem, piece the bits together to actually come up with an appropriate working diagnosis or suitable differential. Okay. In terms of clinical management and complexity, that you're safe and that your management is up to date with current guidelines. So you can deal with the main problem and any other big risks. You think about continuity. You're able to involve the patient in self-management where that's appropriate. And that you also think about, beyond the immediate thing that they've presented with, that you think about other risks long-term. Okay. In terms of relating to others, that you are ethical in your approach, you understand and can apply where appropriate GMC ethical guidance, that you can communicate in a person-centered way, that you sort of have flexibility in terms of adapting your communication and consultation style to the situation, to maybe deal with communication barriers, that you involve the patient and come to a shared understanding. So these are generic things that they're looking for in any case. For each case, though, there's a specific mark scheme of things that are relevant to that case. And what they do is they're going to give you a grade for each of those 3 domains for each of the 12 cases. And so the grades are clear pass, pass, fail, or clear fail. Now, you get a clear pass, that's worth 3 marks as a raw score. What you need to demonstrate for a given domain to get a clear pass is that, were you a fully qualified GP, what you demonstrated was excellent. It was impressive. There was nothing missing. A pass is worth 2 marks. It means that what you demonstrated, if you're a fully qualified GP, they'd be happy that you're competent. A fail is worth 1 mark. And what that means is that you're below the standard for a fully qualified GP to practice independently. And a clear fail is worth nothing. It means either you're unsafe or you're significantly below the standard, or you're below the standard in multiple areas in that same domain. For example, in data gathering and diagnosis, if you miss a really important red flag, such that it's unsafe, so that might lead to a clear fail. If you get the diagnosis wrong and you miss some things in the history, together that might be a clear fail. Okay. Now, if you get a fail or a clear fail for any domain, there are 25 formative feedback statements. They have to give you some feedback when you get the marks and the exam results. And sometimes, even if you get a pass or a clear pass, they might still give you some feedback on some things that you can improve. That's going to be specific to that case. So as I mentioned, you have each case is marked by 1 examiner. It's marked later because the whole thing's recorded. So you will have 12 different examiners in total assessing you. Right? Now, can you see that you can get, therefore, if you can get maximum of 3 marks for a clear pass, the maximum for data gathering and diagnosis and the maximum for relating to others, if you were to get clear pass for all 12 cases, for each of those, would be 36 marks and 36 marks. Clinical management and complexity, the maximum is 54 marks. And that's because they take your raw score and they multiply it by 1.5 because it's weighted 50% extra. Okay. So, if you get a clear pass, that 3 marks becomes worth 4.5. So it becomes amplified. But equally, if you get a fail or a clear fail in clinical management and complexity, it has a magnified negative impact because you're losing more potential marks. So the total marks available are 126. And what they do is the pass mark is different each day based on how difficult are the cases. But you pass or fail the exam overall based on your total score. So for example, if one case didn't go well, if you do well in other cases, as long as your total score is at the pass mark or higher, you pass the exam overall. It's not about passing or failing individual cases or a number of cases. That's not how it works. So the lowest the pass mark's been set so far is 76 out of 126. The highest is 78. Theoretically, it could be higher than this on a specific date. And if we look at the pass rate in the sittings we've had so far, it's varied somewhere around here, okay, with a long-term mean around here. Now, in every day of the exam, the cases are different. But in every day of the exam, they will draw up an exam that has coverage of all 12 SCA case blueprint domains. So every exam, they will have cases that span all of these and all of these. So you'll always have at least one that's related to child health, a patient less than 19 years old. And that could be, a teenager. So you're actually engaging with a simulator who's pretending to be, 14, 15, that kind of age. Or it could be a parent discussing something about a young child, a baby, 1, 2, a few months. Blueprint domain 2, gender, reproductive and sexual health, which also includes women's health, men's health, LGBTQ issues, gynae and breast related health. Number 3, long-term. So that includes things like, any chronic disease, someone with multiple chronic illnesses, disability, cancer. Number 4, older adults. So this could also include frailty and people near the end of life, terminal, palliative. Number 5 includes mental health. So alongside things like depression, anxiety, schizophrenia, it could also include addiction, smoking, alcohol and substance misuse. Number 6 is urgent and unscheduled care. So it could be something that needs an admission, for example, someone who's acutely unwell. Number 7, health disadvantage and vulnerability. So now this could include veterans care, someone with issues around mental capacity, so they've got an additional vulnerability, safeguarding issues, someone with maybe communication difficulties, deaf patient, for example. Number 8 includes ethnicity, culture, diversity, and inclusivity. And so that could also include, lots of different things. Sometimes there's overlap. For example, here we have gender, reproductive, and sexual health, which includes LGBTQ. But under diversity, you should also have things like trans healthcare. Number 9 is someone that presents with something they've got no past history of, or they've never come to the doctors about before. So a new presentation of undifferentiated disease rather than a follow-up. Number 10 could be anything to do with prescribing. Number 11, anything to do with investigations and results. And number 12 is a bit different. Professional conversation and professional dilemma. So in all of the others, it's a patient or a relative or carer of a patient you're discussing with. They're all played by simulators. Number 12, it might not be any patients there at all. You might be having a discussion with the practice manager or the receptionist or the secretary or someone else that you're working with. There won't ever be another doctor, but it could be anyone else that you might work with, while you're working as a GP. And the kinds of things that you might get, you might have a patient who's known to be diabetic, but they're presenting today with symptoms of low mood, and maybe they've got enough there to fulfill the criteria for clinical depression. Now, you see, often things will span more than one area. You see, that spans mental health and long-term condition. So it's spanning, mental health, and then they've also already got a chronic disease. Okay, so that fits here because there's multimorbidity. The having of a chronic disease is a risk factor for having a mood disorder. Okay, so sometimes there's a linkage there. A new suspected eating disorder, suspected anorexia in a teenager. So, that spans mental health, someone under 19 years, but a new presentation of undifferentiated illness. It spans 3 blueprint domains. Someone who's been tired all the time for more than 3 months. So that's a new presentation of undifferentiated illness. Patient with known terminal illness, and maybe they're presenting because they've got very severe pain and they're already on a cocktail of different analgesics and it's still not well controlled. And it's about maybe looking at, is this the stage where we need to think about end of life care? Maybe they need a syringe driver. Maybe they might benefit from a stronger and different type of analgesic specific to their situation. So in terms of the instructions that you're given, you remember you've got 3 minutes to read before each case. Once that 3 minutes is up, they disappear and the simulator comes onto the screen. However, you can still access that information by clicking the relevant tab within the software. Okay, it's not going to be there directly. You have to specifically access it. It will tell you if it's a remote video or if it's a telephone, but it won't tell you which case domains and not necessarily tell you what the consultation is about. What it will always have is some demographic information, so patient's name, age, and then it may include some or all of these things. And I'll give you some examples. So, you're going to have an example like this where you've got some past medical history, their current medication, and maybe they've had some recent blood tests. You could have an example where there might be a relevant photo and they've included that photo submitted earlier that day and they've given you that photo. And sometimes there'll be more than one screen's worth of information. Sometimes you might have temporary resident, no notes available. Beyond their name and age, you might have nothing. But sometimes there might be as much as 3 screens worth of information, and there'll be a little arrow here for you to go to the next page. Okay. So now, if I just talk to you about what kinds of cases and what they might look like, sometimes it's a little bit difficult to picture how it might go. I think it might be helpful if we actually do a sample case. So let's do a sample case, and we'll do this as an interactive case. And then what I'll talk to you about then is, how do you approach preparation? What are the reasons that lead to people failing? And then what are the habits of the high scorers? We'll look at that after we've done an interactive case. So have a look at this information, and then we'll have someone from the eMedica team, Masood Rahman, will come on to play the role of the patient. And I'm going to get you all to be involved. I'm going to ask you to type into the chat the questions that you would like me to ask the patient, and I will ask them exactly how you've written them. And then between us, we'll see if we can draw out some of the key things about data gathering. At that point, I'll pause the consultation, and then we'll talk through some of the theories to see what we might have missed. And then I'll get you to maybe get involved in telling me how you might approach management. Okay, so have a look at the information. Okay, that's great. So let's have a look. What I'm going to do is, just like the exam, I'm going to stop the screen share. We'll paste this information into the chat, so it'll be available in case you want to have a look at it. And I'll just do the introduction and ask the opening question. After that, I'm going to ask the questions exactly as you together type it into the chat. Okay, so try to start thinking ahead about some of the questions that you want to ask. Okay, let me just stop the screen share so we can see myself and the simulator, and we'll take it from there. Hi, is that Rahila Begum?
It is, yes. Thank you for seeing me, Doctor.
Oh, you're welcome. My name is Dr. Rahman. I'm one of the GPs here. How can I help today?
Well, I wanted to ask if I could have the injection that's been in the news.
Okay, so I'm just going to come out of roll now. I'm waiting for you guys to ask what you'd like me to ask the patient. Type it into the chat, and then I'll take it from there. Okay. Perhaps could you tell me a little bit more, or which injection are you referring to?
I can't remember the name of it, but you just give it to yourself once a week, and it's to help you lose weight.
Okay, can I ask why is that you'd like that?
Because I want to lose weight.
Okay, and what have you heard about this injection so far?
That it's easy, that you just give it to yourself once a week. You don't even have to remember to do it all the time. And that people are losing like 20% of their body weight.
Okay. So if it's okay, could I ask a few questions before we talk about whether or not it's possible to prescribe? Is that okay?
Mm-hmm.
Okay. Can I ask, have you tried anything so far to help you lose weight?
I mean, what kind of thing? I walk up the stairs. I live on the second floor, so if I don't have the kids with me, I will walk up the stairs on purpose to kind of do a bit of exercise.
Okay, that's good. Anything else?
Um, that's really what I do.
Okay. And can I ask what your concerns are about your weight?
I mean, when I had my first child, I weighed 50 kilos. And then I had one baby, and then suddenly it's 70. And I had another baby, and now it's 80. Like I've never been this big. And I don't feel like myself. I don't I don't want to look like this. I don't want to be like this. I want to be back to normal.
Okay. And how long is it that you've sort of been thinking about and trying to lose weight?
I mean, immediately after I had my first baby, I, I knew I was putting it on, and I didn't want to be fat. But I'm not. It's not like I've not tried very hard. I have to be honest, because I mean, right now I'm alone with my kids. I just I don't have a lot of time to think about myself. Primarily I have to take care of them.
Mm, right. Okay. And you mentioned about exercise that, you walk up the stairs when you can, and that's the main thing. What about your diet? What types of foods do you eat day to day?
I mean, it is stuff that's easy to cook and quick to cook. So for the fish fingers and oven chips and things like that, things that the kids are eating, I'll mostly just eat their leftovers. When I'm at work, sometimes I'll eat some sandwiches, and it will be something that I've bought rather than something that I've made. I'm really pressed for time.
Mm, okay. And would you say that do you feel that your diet is healthy? Would you describe it that way?
No, no, I don't think it is.
Okay. And have you had any thoughts as to why you've not been able to lose weight? Because you said you've been trying for some time, but uh, you did say that you perhaps haven't tried as hard as you could. But any thought as to perhaps why it's not shifted?
I mean, it's everything else. It's that just life is getting in the way. I'm it's taking the kids to school, then I go to work, then I pick the kids up from school, then I have them all evening. There isn't there isn't time for me to focus on things that I want to do. There isn't time for me to exercise. The fresh ingredients are more expensive than fish fingers and oven chips.
Right. Okay. And have you ever tried like any specific diets?
I tried that one where you don't eat breakfast and you like have a late lunch, and so that you're not eating for many hours in the day. I couldn't really stick to it though. Kind of.
Okay. And how do you think that your weight gain has affected you, sort of in terms of your home life, work life? Is it having an impact?
It's making me miserable. Like I said, I don't feel like myself. I'd like to feel normal. I feel abnormal. I I don't want to be like this.
Right. And when
Um,
you say you feel
um,
abnormal, are there specific symptoms you're having?
I guess I'm tired. I guess that's because I'm carrying all this weight. When I do go up the stairs, I have sometimes I have some pain in my knees, which never happened before I was fat.
Right. And do you smoke?
No,
Do you drink alcohol?
no.
Okay. Is there anyone in your family that's got any serious medical conditions like heart attack or stroke?
Both my parents have passed away from one from a heart attack and one from a stroke.
I'm sorry to hear that. Okay. And I understand that, raising a young family and working, it can be very time consuming. There's lots of challenges with that. And you mentioned the injection, but have you thought about any other ways that we could perhaps support you with making changes?
I mean, unless you want to buy some groceries for me or pay my rent, I don't see how. The
Yeah,
injection would help me.
I appreciate that fresh fruit and things like that can be expensive. Can I ask about some more specific symptoms? Have you had any constipation recently?
Um, I have. I think I've probably had constipation for several years. We're not, as I said, we're not eating very well. It's a lot of oven cooked things, and if I'm out, it'll be fast food.
Right, okay. Have you noticed that you're losing any hair?
No.
Any changes to your skin?
I've been a bit spotty. Yeah.
Okay. And you mentioned that you're not feeling your usual self, and I appreciate there's lots going on. You're very busy. Um, how would you describe your mood?
I mean, it's not great. That's another way that I'm not myself. I feel like I'd be a bit more cheerful if I wasn't so heavy.
And how's your sleep?
It's probably what you'd expect. As you said, I have a lot going on.
Okay. Specifically, do you sort of find that you wake up in the night sort of struggling to breathe, or
No.
snoring is causing an issue?
If I'm snoring, there's no one around to tell me that I'm snoring. So no, I don't think so.
Okay. Have there been any changes to your periods?
No.
Okay. And do you think that your weight is impacting any other areas of your life, like hobbies and you know, um, like things that you can do with your children?
I think if I had more energy, I'd probably be doing more things with the children. Um, but I mostly take them to the park and sit on the bench while they play, and it would be better if I could play with them.
Hmm. Okay. And you mentioned that your work, has this had an impact on your work life? What job do you do?
I work in a supermarket.
Hmm. And is that being affected?
I don't think so.
Do you have any sort of anyone around that could help with things like childcare, so you can get some time to yourself, for example, to, you know,
No, I have no one around.
okay. And you mentioned that your mood, it's not as good as it could be. That you also mentioned about low energy levels. Um, has it ever got so bad that you've had thoughts of harming yourself?
I've had the odd thought, but I would never do anything because I have my children and they're my reason to stay.
Mm. And would you say that you have feelings of feeling sort of helpless or hopeless?
I don't feel helpless.
That's good. Do you still enjoy the things that you used to enjoy? Do you get pleasure or interest in doing things?
I don't have time to do any of the things that I used to do.
Mm. Right. And, some of the things that you've described, it must be really hard. I think it's a really positive step that you've come to speak to me today, and hope that we can work together to improve things for you. Okay, I'll stop there. Thank you very much, Masida. And I'm going to share the screen again. Good. So between us, we've got a lot of useful information in terms of the data gathering. Okay. So, things that you want to explore. Here's an example of some of the specifics that might be in a mark scheme for a given case that, you explore about diet, some of the specifics, portion sizes, how often they have meals, do they have a lot of processed foods? Because there can be hidden sugar, hidden salt, hidden levels of fat, alcohol, specifically about fiber intake. That's important. Ask about exercise, how often, how intense, the duration, um, any factors like in terms of someone like she mentioned, she works in a supermarket. Now, someone that's working, stacking the shelves, they're still quite active. They're lifting, they're moving from one aisle to the other. Someone that works in management, they might be in the office a lot. So getting some of the details, okay? If someone has a more sedentary lifestyle, that's a risk factor. Mood, there were some cues there that suggested that her mood might be impacted. So we could assess that. And beyond that, would you say that when your mood is down, that you might eat more? Comfort eating. Got some details about what they've tried so far. And you want to explore the risk factors. Type into the chat, what are some of the risk factors for obesity? Because we explored some of these, but sometimes in a given case, there might be some things that sometimes people miss. So what are some of the risk factors? Okay, great. But between you in the chat, you've actually got most of it. So these are the known risk factors for obesity. So as people get older, there's an increased risk. So the highest incidence is actually in those 55 plus. Sometimes there could be a medical condition underlying. So asking certain questions, like we asked about periods, for example, asking about things like hirsutism, if you're thinking about things like PCOS, Cushing's, metabolic syndrome, hypothyroidism, so constipation, feeling cold, dry skin. We already know that she's got weight gain. Okay, perimenopause and menopause, some of the hormonal changes there can be a risk factor. Prior pregnancy, sleep deprivation, having less formal education or low socioeconomic status, and then genetics. Okay, something else that's important. If I put back the screen here, we have here, remember in the actual exam, because the patients aren't there, it's remote, you're never going to examine someone. Sometimes there can be important exam findings, and in some cases, that might be given to you in some way, and it's up to you to use that information. So you can see, look, here, we were given the body mass index. What does that put this patient into? What category? Are they overweight, obesity 1, obesity 2, obesity 3, healthy range? Obesity 1. Yeah, great. And then we've got some important information here. Waist circumference and height. Based on this, is this patient's waist to height ratio put them at increased risk or not? Are they in the healthy range? Let me show you a really simple way to do this, okay? The threshold for increased risk is 0.5, a waist to height ratio of 0.5 or greater gives with it increased risk. Once you get to 0.6, even higher, but anything above 0.5 is increased risk. Under 0.5 is healthy. So a simple way to look at it is if the waist circumference is 90, anything less than 180 for the height, that's something hopefully you can do in your head because you haven't got a calculator, okay? That, if this was more than double, if it was more than 180, then the ratio is going to be less than a half. It's going to be in the healthy range. You can see if this is 90, this is less than 180, this is definitely going to be more than 0.5. That suggests increased risk. It's an easy way to do it, okay? So if this is not lower than half of this, there's increased risk, okay? So in terms of calculating it, how might you explain to a patient how to actually do the measurements? If you look at what the guidance is, they should find the point of the lowest rib and find the top of the hip and look about halfway. That's quite complex. An easier way for most people, if they put the tape measure right around where their belly button is and use a flexible tape measure, that's going to give them their waist circumference. That's in most cases, close enough to that midpoint to give you that. And then most people know their height. As long as they're both in the same units, you then just take the waist reading and you divide it by the height. So 0.4 to 0.49 is the healthy range. Anything above 0.5 is increase. And once it gets to 0.6, it's even higher. Okay. And in terms of management, this patient wanted the injection. How are we going to approach that? Are we going to prescribe the injection? Are we going to refer to hospital to be considered for a different injection? Are we going to prescribe her some tablets? Are we going to, how might you approach it? What would be an appropriate way to manage this case? So yeah, because she hasn't really made and tried dietary and exercise changes yet, she's not eligible for medication at this stage. She said herself that, she's not really had time And that often is the case. There might be someone that would like to lose weight, but it's expensive to eat healthily. They've got a lot going on. They haven't got support. They haven't got time to go to the gym. And so we've got to think about what's workable for this particular patient. Sometimes it can be smaller things. So she mentioned she takes the stairs when she's not with the kids. Could she take them even when she's with the kids? Could she try going for a walk? Small things, and then building up. Okay. But that she's not eligible for medication at this stage. But if she makes changes to diet and exercise, actually, she might be eligible for Orlistat after that. Okay. What she would benefit from at this stage, some structured advice on diet and exercise. So, keep a food diary, then we could refer her on to maybe a dietitian who can give them a tailored thing with their constraints in mind, signposting to those additional resources and support, and to discuss some of the barriers to change. Sometimes they can be economic barriers, right? In some cases, depending where you are, there might be things like, has anyone had in their area, one of the practice I worked at, we used to have this thing called exercise on prescription, where if someone couldn't afford to go to the gym, but had the motivation to do so, and they were overweight or obese, so there was a risk, we could actually prescribe, if you like, exercise. So they either got free or subsidized gym membership. Okay. That's available in a lot of areas. Sometimes they might have some physical health needs. And then, if someone has got mood-related issues, that might be a separate, like there's enough there that you might think it might be worth having a separate appointment to actually talk through that, because they might benefit from help with that, because that can be like a vicious cycle. Some patients, when they've got mood disorders, they're feeling down, they comfort you. Then they get upset because they're overweight and obese and not losing weight, and then it's a cycle. Do you see what I mean? This is taken from our clinical case cards, which is a concise way to revise lots of different clinical guidelines. But just to get some of the key information that, one of the things is to know the thresholds, right? So this patient is in obesity 1. Because she's from a South Asian background, she's actually quite close to obesity 2, because obesity 2 for patients with increased genetic risk from these backgrounds kicks in at 32.5. And she was already 31 and a bit, wasn't she? Okay. So, she's definitely into obesity 1, but she's actually at risk if she continues to put on weight to get even higher. And then, waist to height ratios. So if someone's overweight and they've got a healthy waist to height ratio, then just sort of general advice on healthy eating, or maybe a link to these are some general things that make a healthy diet. This is how much exercise you should try to do generally, is often enough. If someone's overweight with increased risk, then you want more specific behavioral interventions. Perhaps get them to keep a food diary, refer them to a dietitian, get a specific tailored diet plan for them. Once they get into obesity 1, then once they've done that, if they're still at risk, having lost some weight, if they're still, in the obesity category, then they might need medication. And I'll talk to you about the ones that we can prescribe in general practice. Obesity 2 and 3 are almost all going to need medication, but depending on additional risk factors, may also need referral for bariatric surgery. So in terms of drug treatment, the one we can prescribe in primary care for a patient like this is Orlistat. But we wouldn't do that until after they've made changes to diet and started doing exercise, and we've evaluated that. And maybe they've lost some weight, but maybe they're still at increased risk and they've plateaued, not reached a healthy range. That's when we might think about Orlistat and the threshold to prescribe that in primary care. Body mass index of 30 and above, even if they've got no other risk factors, or 28 and above if they've got other risk factors, like they've got established cardiovascular disease or they've got diabetes, for example. Okay. And then in terms of the newer injectables, the one that the patient was talking about, what do you think it is? They probably think about Mounjaro, right? Okay. That's the brand name. The drug name is tirzepatide. And very recently, it's been in all the papers because it's now prescribable in primary care, but in very specific situations. Before that, semaglutide has been prescribable in the NHS only in secondary care. So they'd need at least one weight-related comorbidity and then a body mass index of 35 or above, or 30 to 34.9, and meet the criteria to be referred to secondary care specialist obesity services. So often that would mean we've tried things in primary care and it's not worked. But tirzepatide, Mounjaro, the nice guideline for that allows it to be prescribed if they've got at least one weight-related comorbidity and a body mass index of 35 and above. So this patient wouldn't be eligible. And while that's what the guideline says, actually the funding for it in the first year of its launch, in terms of what's being funded in different areas, in most areas, actually you need 4 weight-related comorbidities and a body mass index of 40 and above. So it's one of these things that what comes up in the paper, people have just hear it, and they often, some of you, let me know in the chat if anyone's come to see you this week, because it was only in the papers, it's just been launched. Have you seen someone come and ask for it? Because what's not always clear in the papers and on the news is what's the strict eligibility. It's very strict eligibility criteria, okay? And there's often this disconnect that things go out without actually putting all the information out. So you can't blame patients. They're desperate to lose weight. They're in a really difficult situation, and they've heard, oh yeah, it's a miracle cure. You just inject yourself, and then people losing bags of weight. They've probably seen lots of celebrities who have successfully lost lots of weight with it. And so while it can be, at the moment, it's very, very restricted. But see, this patient could benefit from orlistat once they've made some changes, and that might help them, okay? So in terms of relating to others, that's, remember, the third domain. It's really important to show lots of empathy, but they've got lots of really difficult factors that making it challenging. To use non-stigmatizing language, to focus on health, not the appearance, to commend them. Well done on coming. It's really hard to lose weight on your own. Lots of patients need support, and it takes a lot of courage to come in and ask for help. So thank you for coming in. Let's work together, okay? To pick up on some of the cues and acknowledge the distress and frustration. The other thing is, remember, to do all of this in 12 minutes, you've got to really focus on your data gathering. There's lots to do there because you need to allow some time to discuss the management. Okay, good. So I hope it's been helpful to go through a case so that, now when I talk about the rest, it becomes a bit more alive for you. So let's talk about then how to prepare, and then we'll talk about the common factors in those that fail. We have lots of people who are resitting. We also have lots of people that come before the first time so that they can pass first time. But we have a lot of people who have often tried other things and they're on their third or fourth attempt, and then they come to us for help, okay? And over the years, we've been researching what are common factors. So let's look at how to prepare first. First thing is that get comfortable with sort of 12 to 15-minute consults. If in real life you're still struggling with 20-minute appointments, this is probably not the right time for you to be sitting the SCA. Just give yourself more time to get there rather than rushing. It's available 9 times a year. Someone that, let's say this is the past standard, and they just fail by a few marks, one of the things I often see is really knocks their confidence, and then they rush to resit, and the second time their marks actually go down sometimes because they start doubting themselves and doubting everything. They try and change everything rather than working on the specific things that they need to change. All right. Now, there's some positives in terms of in the exam, in that you're not physically going to examine, and so that saves some time. But equally, and you're not needing to type up any notes and so on. So in real life, if you're coping with 15 minutes, once you account for those things, you should be able to cope with 12 minutes. Okay, but if you're struggling with 20, just give yourself more time. Practice cases with a timer and in a study group. A good number in a study group is 3 of you. One to be the doctor to have a go, one to sort of learn a role and play the patient, be the simulator, but one to observe, take notes during the consultation, and then give detailed, critical but constructive feedback. Because one of the things in a study group is sometimes people, they don't use a timer, so they just relax, they let it go on. And if you had 20 minutes, everyone would be able to get more marks. But you don't realize how quickly 12 minutes goes, and you're like, oh my gosh, I still haven't even finished explaining the diagnosis. Well, if you haven't finished explaining the diagnosis, even if you know the management, you automatically get a clear fail for management because you haven't got to the management domain at all. The examiners can only mark what they see on the recording. Remember that no one's marking live, so they can't clarify anything. All right. They're watching a recording at a different point in time. So be strict with time. But also, another thing that happens sometimes in study groups is everyone just tells everyone, oh yeah, you're great, you're great. Vague and positive things. They won't be specific, and they don't want to say anything critical because they don't want to upset anyone. If you, at the beginning, say, look, for us to improve, we need to know what we need to change. Let's all agree that we're going to be critical but constructive. Okay? Equally, if you're in a group and someone just says, oh, you're awful, you're never going to pass, that's no good. That's not going to help. But if they point out, actually, the way you said this, it was unclear. This might be a better way. You missed this red flag. Without that, you might miss this diagnosis. Do you see? Because if people only tell you what you're doing well, you don't know what you need to change, and so you never change it. Okay. Try to do lots of observed consultations and get feedback everywhere. So, you could do joint surgeries where your trainer watches you. You could do reverse joint surgeries. You sit in with experienced doctors, watch how they consult. And, you might think, oh, I really like the way they explained that. Oh, that was a nice little trick. I found that really helpful. Take that, add it to what you're already doing, and then work on it until it feels natural. Okay. In your tutorials, do role plays. If you're doing out of hours, ask someone to listen into one of your calls, give you feedback. Because remember, 3 out of the 12 usually are going to be telephone consults. Ultimately, you want to get comfortable in your own skin and develop your own consulting style. We're all different. There's not only one way to communicate. And if you try to change everything that you feel comfortable with in consulting, because you've read something in a book and try to do something completely unnatural to you, it will come across as really awkward on the day of the exam. So, you can change your consulting behaviors, but it takes time, it takes practice. And rather than change everything, keep the things that you're doing that are already good. And there might be some things that you can take from other people to make it even better. And then it takes time to then practice. So then it seems natural. You get comfortable in your own skin. Something really important, more than 2/3 of the marks, because the data gathering and diagnosis is clinical. The clinical management and complexity is clinical, and it's weighted 50% extra. So more than 70% of the marks are clinical. You've got to know your stuff, revise your core knowledge. Your guidelines need to be bang up to date. So you know what questions I need to ask. What are the red flags for this condition? What are the criteria for urgent referral, for admission, for non-urgent referral for this? What's the current evidence base on this? Alongside that, you need to be able to manage your time, to communicate clearly, to pick up on cues. So you need practice. Get comfortable and actually practice doing some of these things remotely. So actually, when you do your study groups, some of those study sessions, especially nearer the time of the exam, try to do remotely. So you get used to, because it's a little bit different. There's a slight delay, and then sometimes you're speaking at the same time and things like that. Practicing telephone consults where you can't actually see them. So you miss the visual cues. You just have to listen carefully. And then a lot of people find it helpful to attend a course where they're going to get individual feedback. So our SCA intensive course, for example, in one day, you see 20 role plays. We have very experienced male and female simulated patients. So, because one of the things in a study group sometimes is that the doctor playing the patient will sometimes, if the doctor uses jargon, they know it because they are a doctor and they'll just carry on. Whereas our simulators, if you use jargon and say, I'm sorry, what does that mean? I didn't understand that. And just like in the real exam where they're trained to do that, you then lose time because you have to go back and explain it again more clearly. The simulators are trained not to just give out all the information. They'll give you a cue, and only if you explore the relevant cue, then you'll actually be able to be given the next bit of information. Do you see? And so, our simulators are trained to do that. And so you get a chance to see lots of cases, but you'll also get to do a full mock case with detailed individual feedback, and you get to do an interactive case where you focus on the data gathering and get some feedback. And you also be able to see other people getting their feedback, and you can learn a lot from that too. Okay. So why do candidates fail the SCA? So this is based on things that we've directly observed, but also looking at feedback reports and looking at data. Number one, sitting it too early. Some doctors are in a rush to just, as soon as I get into ST3 and I'm eligible, let me take the very first sitting in September. And you know what? Some people might be ready then, but a lot of people won't be. Remember that the standard that they're assessing you against is not, is this good for a registrar who's still got 8 months left or 9 months left or 6 months left? The standard is this good for someone who's a fully qualified GP to practice independently and safely? So without a supervisor and with no one else in the building. That's the question they're asking. You're much more likely to be able to consult in that way when you are towards the second half of ST3 than you are in the first couple of months of ST3. Do you see? And as I mentioned earlier, someone that rushes to sit it early and fails that first time, I've seen some doctors, it really knocks their confidence, and it takes a lot of time to build back up that confidence to successfully pass. And often their second sitting, they actually either improve very marginally, or I've seen some that got worse the second time because their confidence just got affected. That same doctor, if they were already close, if they just delayed it 2 or 3 more months, consolidated the knowledge, got more comfortable in their consulting, practiced more, got more feedback, they wouldn't have passed, they would have smashed it. They would have scored 100 plus. Number 2, unable to make management plans. Now, this can be because they just run out of time. That's a common reason. So it ties into poor time management skills. That, remember, that getting the diagnosis does not get you any marks for management. Data gathering and diagnosis are one domain. If you get the diagnosis right, and you might in your mind know the management, but you've just finished explaining, and when you explain a new diagnosis to a patient, what's a common thing that's going to happen? You've just told a patient that they've got diabetes. They're going to ask questions about what does that mean, and about, are there things that they can't do? And I heard that someone lost their foot because of diabetes, or am I going to have the injection? Before you can actually talk about the management, and it might be someone that you need to explain about starting metformin, for example, and so on, they're often going to ask questions about a new diagnosis. Okay. And so if you haven't actually discussed management at all, you automatically get a clear fail for that, 0 marks. So sometimes it's that they just haven't got there. Other times it's that not committing to a management plan, or not knowing the guidelines. So therefore they're hesitant, or they just suggest the management, but it's not up to date according to the current guidelines, or it's not specific. Poor history taking skills. So being a little bit scattered in the approach to history, not being focused, asking lots of vague, irrelevant questions, asking the same questions to every patient rather than asking focused questions relevant to their presentation. Missing important red flags. So it's an unsafe history. Poor time management. So that leads to issues generally with management. Being doctor-centered in the approach, not involving the patient when it would be appropriate to involve them. Having poor active listening skills. So as I mentioned, the way that the simulators are trained is that they're trained to deliver certain cues, certain lines. And someone that doesn't explore that cue, there might be other useful information they're specifically told, don't give this out unless they explore this cue. So if you miss that cue because you weren't actively listening, you may not ever get that important piece of information. Poor sensitivity, poor rapport building skills, poor communication. Okay. So this can have an impact on the relating to others. The problem with poor active listening skills, not only will it affect your mark for relating to others, but if because you didn't explore that cue, you don't get an important piece of the history, that might affect your data gathering. That might mean you don't get the right diagnosis. That might then also affect your management and complexity. It can affect all 3 domains. Okay. That said, the most common reason in terms of domains for people to fail is actually the management domain. It's not communication. Okay. So what happens if you fail? You'll be given feedback. You'll get your domain scores. So you'll get what was your score for data gathering and diagnosis, what was your score for clinical management and complexity, for relating to others overall and for each case. And you'll also get those 25 feedback statements. How many of those applied to how many cases? So you can see, I need to work on this. Okay. Really important. Hopefully you all prepare well. You sit it when you're ready. You pass first time. The nature of any exam, some people will not pass first time and might need more attempts. What's really important is that you don't then approach your preparation the second time in the same way as the first time. If you keep doing what you've always done, you're going to keep getting what you've always got. So it's important that you get extra support, get extra training, get additional feedback, increase your number of observed consultations. Don't rush to resit when it's ready. If you didn't go on a course where you got individual feedback, go on a course where you can get individual feedback. Consider getting some one-to-one coaching. Now let's look at the opposite. What are the habits of high performers? And then we'll talk about useful resources and what we offer for those that want support for SCA, because we've got a whole range of things. So number 1, those that I've seen that score really well, 100 plus, they plan ahead and they start preparing early. So they'll often start forming a study group 6 months before they're going to sit the exam, and just doing some regular practice. And then 3 months before, they may be meeting once a week. And then as they get very close to the exam, they might meet once in the week. And on the weekend, they might meet for a couple of hours and do some more intense practice. And then a couple of weeks before the exam, they'll do a full mock in their study group. Okay. Whereas those that don't plan ahead, leave it late, they're going to struggle. Number two, they seek feedback, but they actually have insight and are willing to listen to feedback and make changes. Because sometimes someone will say they want feedback, but as the person's giving them feedback, they've already got a closed posture. And anything they say, they're like, no, I said that. No, I didn't. You missed it. And if you have that approach, what happens is two things. One, you're genuinely not going to take on board the feedback and be willing to change. But number two, the person, how do you think the person giving feedback, who's trying to help you, who maybe is giving up their own time to try to give you this feedback, is going to feel if someone's got a closed posture and gets very defensive about every bit of feedback instead of taking it on board? They're going to think, this person doesn't want help. They're not willing to listen. I'm just going to use my efforts and my time elsewhere. They're not going to want to support you further. Number three, they develop good consulting habits in real life. Okay. You shouldn't be doing any acting in the SCA. Leave that to the simulators. Let them do the simulating. You should be doing what you do on your best day in clinic. So if you develop good consulting habits in real life, you don't need to fake anything for the exam. You've just become a good consultant. Number four, consolidate your knowledge base. Knowledge is power. If you're really confident in your guidelines, you know which patients are eligible for which treatments. You know what the right management is. You know what the current guidelines are. You know that, look, I'm running short of time. While it might be nice to ask this, this, and this, they're not essential. I must ask these red flags. I must ask this and this. It could make the difference in terms of what the diagnosis is. So, having good knowledge base helps you with your data gathering, helps you to explain the diagnosis more clearly and confidently, helps you to know the management so you can deal with that concisely. Number five, they communicate effectively. So they actively practice, they take feedback, they take it on board, and they work on their communication. So they can say things clearly, concisely, confidently. They show empathy and sensitivity. They're genuinely person-centered. They involve the patient where appropriate. Number six, work on time management. Okay. Sometimes this goes hand in hand with this, that, people that start early, it takes time to build up to being able to consult in 15 minutes. Even then, that's challenging. But once you've got there, then you can sort of comfortably do these things in that time. Then you should be okay to manage with 12 minutes in the exam, because you're not going to have to examine and type up your notes. And number seven, this is really important. Practice cases from all of the 12 case blueprint domains. Don't just rely on what you're seeing. Everyday consulting is a great practice tool, and looking up the guidelines whenever you see any case where you think, oh, I didn't know how to deal with that, or that's new to me. That's a good way to learn on the go. But you need some intentional practice. What I mean by that is, some of you might not see a lot of women's health. Let's say you're a male doctor in a practice where there's lots of female GPs, including one who has got special interest in women's health. So the patients know what the doctor's interests are over time. So if they know that, a lot of them will naturally go to that doctor. And so you might not see as many. Similarly, if you've got lots of male GPs in a practice and you're the only female registrar, you might find that, a lot of men with prostate issues and erectile dysfunction and things like that, they might prefer to go to the male doctor because they know they're probably going to need to get an examination, and they get a bit embarrassed sometimes. So you might find that you're just not getting enough practice with that. You might be in an area where there's a sexual health clinic, GU medicine that's fairly accessible, and a lot of patients just go there directly. So you just don't see that much of the sexual health type stuff. Don't wait to the exam to find, actually, I'm not confident in this, I get a bit embarrassed in this, or I'm not sure how to do this in a smooth way. You want to actively practice from all of those 12 blueprint domains. Okay. And I'll show you a way that you can do that in a minute, but because we're going to move on to useful resources. So the first thing is, make sure you definitely look through all of the information on the official RCGP SCA page, because you get authentic information there on the format, the marking. There's some sample case videos, some sample of the case notes that you're going to get. But in terms of intentional practice, this is something that you might find helpful. So we published the first ever SCA casebook. Last year, we were the first ones to publish a textbook specifically mapped to the SCA mark scheme, because the mark scheme is different for SCA compared to both CSA and RCA. So it's 400 pages, there's 75 cases. Every case, there's a doctor sheet in the same format as the exam. There's a detailed script, often running into a couple of pages. So, whoever's going to be the simulator in the group, they know, okay, these are the opening lines. These are the sort of main concerns. These are the symptoms. These are the things I don't have. This is how I should answer if they explore my ideas, concerns, and expectations. This is how I should behave. This is what I should do if they say no to the medication. And you want to read that and learn it if you're going to be the simulator before you start the case. And then probably the most important thing is that for every single one of those cases, there's a detailed examiner's sheet with a specific mark scheme for that case mapped to the SCA domains. And then there's additional, like there's sort of learning points from the case and a link, like a QR code that you can scan to go to the guidelines to actually consolidate the knowledge base with up-to-date guidelines. Okay, so this is our SCA casebook. We've had excellent feedback, both for SCA. We've also had doctors use it for the MICGP, that's membership of the Irish College of GPs. They have an exam that's based on, similar to the CSA or SCA, they call it the CCT. Bit confusing because in the UK, when you finish your MRCGP and your GP training, you get a certificate of completion in training, but that's the name of the exam there. But we've had some great feedback. There's lots more on the website. So that's available in print, 400 pages, A4. It's a big, hefty textbook. Okay. And there is also, if I just show you actually, on our SCA section, we've got all of our courses, but also the books. But just specifically for the book, you can buy just one. It's only available for delivery to the UK from our website. Or at the bottom, and you can see a sample there, we also have, you can get a study group pack. So basically, it gives you 3 case books and you save £30. You save £10 on each one because they're being delivered to one place. Okay. So, if you've got 3, you've each got your own book. So that the person who's being the simulator, they're reading their notes. The doctor, when they're told you've got 3 minutes to read, they read their doctor's case notes. So look, here's what the doctor sheet looks like. Okay. And then the simulator can see there's detailed script, what symptoms, the opening line, other questions that they might ask you. Then the examiner sheet, you see it's specific, detailed mark scheme. It's not generic. It's specific to the case. And then there's learning points and a link for you to go to the relevant guideline for further reading. Okay, and you can see all the different cases that are covered. And there's a full mock case. So we've put the last 12 cases. They're arranged to be used as a full mock, or you could split into 2 as 2 half mocks. But in the full mock, it covers all 12 domains in that one mock. Okay. Now, if you want to study remotely, if you don't want a printed book, then the same cases are available on our SCA cases online, the same 75 cases. But alongside that, there's additional material. There's some videos, some examples of a couple of consultation videos, and there's information about the exam and how to prepare for it. Okay, but the cases are the same. That sometimes people that either want access from different places, want it remotely, or just prefer to study online using a tablet or a phone, that they prefer. If you prefer to have the printed book, that's available in the UK via our website. If you want to get it outside the UK, you can get that from Amazon. So if you just type SCA cases into Amazon, then the book is available outside the UK. They print it and deliver it directly from the nearest centre to you. If you want to consolidate the knowledge base of lots of cases, we have our GP 100 case crammer videos. So how I talked through the key things in data gathering, then the current guidelines for management, and the things to think about in relating to others for that case around obesity. We've done that for 100 cases. We ran it as a long course, and we recorded over 8.5 hours worth of videos. For each case, I discuss, what kinds of things that you want to explore in the history. What are the key things to cover? Red flags not to miss. What examinations are important, because it's not just for the exam, it's also for everyday consulting. What are the current guidelines for management? Follow-up, safety netting, how to explain things clearly. And they're mapped into blocks of 5 cases. So like each one of these videos might be half an hour to 40 minutes. So the first 4 I discussed, the 5th one, there's a simulator, and you'll see that the audience are asking questions, the simulators answering questions, a bit like we did with the interactive case, and then I discuss the theory after. So it breaks it up. So there's 100 cases, and it comes with a 362-page PDF booklet, which has the teaching slides from the videos. These are all the cases covered. And then our SCA Essentials half-day course, 4.5 hours worth of videos. It covers in a lot more detail than we can today, because we had an hour for everything. I told you there's those 25 feedback statements. We cover what they are, because if you know what the things are that might be flagged and that are negatives according to the examiners, you can learn how to avoid them. We look at how to structure a consultation, how to use the CARE model for SCA. We have key communication and consultation skills, how to break bad news, your consulting toolbox, how to use ICE appropriately, the 3 C's of effective communication, some tips specifically for remote consultation, managing the technology side of things. And then there's 6 interactive cases that we go through, okay? And again, it includes a booklet. Now, all of that plus more is available in our Pass the SCA bundle. Okay, so this is one of our most popular products for SCA. So basically, you've got the 4.5 hours worth of videos from our half-day SCA course. You've got the 8.5 hours worth of videos from the GP 100 case grammar. You've got access to the online 75 SCA cases, including the consultation videos, those 2 consultation videos. You get 3 textbooks in print. So our SCA casebook, the printed version of our GP 100 case grammar booklet, and then the Scion Publishing cases workbook for the MRCG, which was published after ours, but is also mapped to SCA. Okay, so you get 12 months access to all of this. You get all 3 books delivered to anywhere in the UK, and you save over £200 compared to if you were to buy all of these separately. We don't need any codes, the discounts automatically applied. So again, if I show you, if you go back to our homepage, there's the SCA section, so the Pass the SCA bundles here. Okay, and you can either just pay for it in one go, or you can click here, and it will take you to the page where you can pay it in 3 installments. Okay, so the first installment now, and then the other 2 installments 2 months later. I mentioned earlier our full day intensive. So a full day intensive, you have 20 live role plays seen throughout the day, and you'll all get detailed individual feedback on your own consultation and communication skills. We have both a male and female simulator, very experienced, and there'll always be 2 people assessing. So I'm there, and either Masuda or Anna from the core eMedica team will also be there to give feedback. Okay, now all of that, so all of this and the intensive and 2 hours of one-to-one coaching is available in our top bundle, which is our SCA Pass Plus bundle. So you get everything in the Pass the SCA bundle, plus you attend the full day course live over Zoom, plus you get 2 hours of one-to-one coaching. So, normally people will do 1 hour shortly after doing the full day course, where they've already had some feedback, and then they'll get some more individual feedback. Then they'll do another hour, maybe a month before the exam, so that they've worked on it, and then they can fine tune as that run up to the exam. Okay. And so that bundle, compared to buying all of that separately, you save over £350. Now, what a lot of people do is they get this so that they can start watching the videos and consolidating the knowledge. They can start reading the books and doing some practice. And then later they decide, okay, now I'm closer to the exam, because you get access to all of this for a year. Now I'm closer to the exam. I'd like to now join the live course. You can then just upgrade. You can pay the difference to upgrade to this, to attend the course and get the 2 hours coaching, or you can pay a smaller amount if you just want to join the live course, to upgrade to just add this if you don't want the one-to-one coaching after as well. But you've got that choice. Okay. To save some time, I'm going to answer some of the most common questions that people ask about SCA, and hopefully it covers a lot of the things that you wanted to know. If you've got any other questions after that, please ask them in the Q&A. So, common question: can I do the exam from home? No. It has to be done in an approved GP surgery. Usually it will be in your practice. In a very small number of cases, if your practice can't meet the technology requirements, you might go to a different practice in your training scheme to do it, but you can never do it from home. Another question people want to ask: can I look things up? Like in real life, you might check the guideline on the official NICE website or NICE CKS, or you might look up BNF online to check the dosage. No. You can't access any other sites. All other resources are disabled when you use the software they use for this exam. Another question: can I use the paper BNF or BNFC? No. That used to be allowed in the first year of the exam, but since September 24, BNFs are no longer allowed at all. So you can't access it online. You can't use the paper BNF in the exam. Can I make notes during the consultation? Yes. So there's either a digital like on the software, there's a little button for a digital whiteboard, or you can have an actual whiteboard, but all of the notes must be destroyed at the end of the exam. Okay, can't take anything out. Can I sit the SCA before the AKT? Yes, you can, but that would mean delaying AKT until ST3. So what a lot of people try to do is do AKT at some point in ST2. So in ST3, they only need to focus on this. And then once they've done this, there's still lots of other things to learn to get you ready for life as a fully qualified GP. But it's not like a part 1 and part 2. You don't have to pass AKT to be eligible for SCA. And some doctors will sit the SCA early in ST3. Often, if they haven't passed AKT yet, for example, and then they take a break and then they come back and they sit the AKT after. But if you are willing to wait till then, you could sit the AKT after SCA. Okay, so those are some of the really common questions. Another question that I often get asked, I haven't put it on here because I already covered it earlier, but just to be clear, sometimes people say, how many cases do I need to pass the exam? It doesn't work that way. You don't pass or fail cases in the SCA. You pass or fail the exam overall based on your total score. If your total score is at the pass mark or higher for your date, you pass. If it's lower, you fail. That's it. There's nothing else. Okay, so don't worry if one case doesn't go well. You still might have got some marks, right? Because you get marks for each domain. Just focus on clearing your mind and doing the best that you can in the rest. And hopefully in total, you do well enough that your total score is above the pass mark or at the pass mark, and then you pass over. Okay, so any other questions, please put them in the Q&A. And what I'm going to do is, for those that haven't got questions, let me summarize and finish, and then I'll come back, and I can see the team have already answered lots of questions. So look, the SCA is a comprehensive and challenging exam. Remember that the pass standard is the standard for independent practice. So they're looking for someone who's ready to work as a fully qualified GP without a supervisor. So what they're looking for is everything. That you've got great history taking skills, that you've got good diagnostic skills, that you're up to date in your knowledge in terms of how to manage things, that you can deal with complexity, that you can relate to others, you've got great interpersonal and communication skills. You must be able to manage your time effectively. And having honest individual feedback will be really helpful so you can work on what you need to work on. And then ultimately, learn, get confident in your knowledge base. You want those guidelines to be right at the tip of your brain. And then after that, practice, but make it intentional practice. Okay. And it's good to get some feedback and then practice so that you practice the right things. Because if you do lots of practice, but without any guidance and without any feedback, sometimes you just become really good at the wrong things. You can just become really good at demonstrating things or doing things in the wrong way. So that's why you want intentional practice with feedback. Okay. But, you can practice in a study group, and we've got resources to help you with that. You can study it on your own, like the GP 100 case scrummer. You can watch those videos and just learn the background yourself. And then you can practice with feedback from your trainer. We offer it at our course. You can get that from your study group as well. Ultimately, I leave you with this from Aristotle, that we are what we repeatedly do. Excellence, then, is not an act, but a habit. You see, if you know your stuff inside out and you are consulting really, really high level in real life, when it comes to the exam, just treat it like a surgery. And what will shine through to the examiner, here's someone who knows their stuff and is ready to be a great GP. And you'll smash your exam. And come the result, I'll get an email just to let you know I smashed my SCA. Okay? That, you won't be faking or doing any acting or doing anything that you're trying to completely change on the day of the exam. You're just being you, and you've become great. You've become an excellent clinician with great working knowledge of GP, who's a great communicator with great consultation skills. And then just be you, and that will be more than enough. Okay, so I hope you found it helpful. Huge thank you to Medical Protection for running this with us and helping support you guys. And all of our team and the Medical Protection Society wish you all the best with your SCA. Prepare and you will succeed.